According to the World Health Organization, in 2012, 92,000 European men died from prostate cancer. Up to 40% of men who are treated for early stage or localized prostate cancer go on to develop incurable advanced prostate cancer. Professor Anders Bartel from the Lund University in Sweden and Professor Wolfgang Leudel from the Hospital of the Sisters of Charity, Linz in Austria, are two of the world's foremost experts on prostate cancer. They will share their thoughts with us, and between them, they have authored over 250 peer reviews and articles and have spoken at the most important global conferences on prostate cancer. Their opinions have been shaped by the professional activities which include leading some of the major international clinical trials that led to the approval of many of the most widely used anti-prostate cancer drugs, and their clinical activities that bring them into contact with thousands of men with prostate cancer each and every year.
What is PSA?
PSA is a simple blood test. PSA means prostate-specific antigen. It's found in the prostate, and we can find out if, for an elevated test, it could be possible that the patient had malignant illness.
Prostate-specific antigen, or PSA, is a protein produced by cells of the prostate gland. The PSA test measures the level of PSA in a man's blood. PSA has been the most widely used biomarker for screening and monitoring of prostate cancer since the late 1980s. But over the last 5 years, as the medical community has learned more about prostate cancer, the role of PSA to monitor how you're progressing on a particular treatment has been challenged, particularly by important clinical trials such as the Alsimpica and Impact trials.
If I was a patient, how would my oncologist or urologist use PSA when they're about to offer me a new treatment?
First of all, PSA is to find prostate cancer, and more specific, it's to monitor cancer. Therefore, if you have kind of stage of prostate cancer and treatment, we should have certain values. For example, if you have a radical prostatectomy where the organ is removed, the PSA should be 0. If it's just with radiotherapy, the movement of the PSA after therapy is more important.
So what is the role of PSA there, and how reliable is it, and to what extent?
If it's a locally detected prostate cancer, PSA is just one little piece of all these puzzles that we have. We have the rectal digital examination, and we have the amount of specimen that is positive. But not really, the PSA is not really finding out if there are metastases. If it's just higher than 20 nanograms per ml, it could be that there is some kind of metastasis, but below it's not really specific.
So if you compare a man with an early disease or with a more advanced disease, what role does PSA play then? What's the difference?
The difference is that we have in the very early cases the detection, and in the follow-up it is very important also for the locally found cancers. In the advanced, let's say in the metastatic site, PSA has in the beginning, when hormonal therapy started and after hormonal therapy, a very important place.
Are there any other biomarkers if we don't rely on PSA in all situations? What other biomarkers are there in early disease and in more advanced disease?
In early disease, as I have said, the specimen, the amount of positive specimens, the PSA value before diagnosis If there is an elevation of 2.0 before the diagnosis, it could be a dangerous case. In the metastatic side, we have the performance status, the LDH, the age. Age is always a kind of prognostic factor, and also a factor what is called alkaline phosphatase, which is primarily found in cases where the bone is involved.
Yeah, we know that there are some recent, very interesting studies, like the LTIMCA and we have the IMPACT trial. And we know that there are patients with advanced prostate cancer that were studied. And we know that PSA was not very reliable in these studies. What about the role of PSA? What's your opinion about it?
Normally, all our patients are really regarding on the PSA tests. And in this setting of metastatic disease and treatment before, PSA is not really reliable anymore. And it is a very big difficulty to discuss the issue with our patients and with the relatives of the patients, because everybody thinks PSA is the absolute denominator. We think that at a certain stage we shouldn't talk about PSA anymore. We don't draw PSA tests that much anymore. And in the new studies which are coming out now, PSA tests are blinded. So the doctor and the patient doesn't know. So it takes quite a discussion to talk to our patients about this issue.
Both of these trials showed PSA is not a reliable progression marker in certain stages of prostate cancer, or for a patient undergoing treatment with next-generation therapeutic. However, in the absence of reliable alternative, men with prostate cancer and the urologists have become the use of relying on PSA as their guide for the extent of the disease and how they're responding to the treatment. Unfortunately, relying on PSA is not appropriate in all stages of prostate cancer, and men with prostate cancer are often unaware of this.
So now when we have new drugs that works well and show survival benefit, the response in PSA is not really what we expected. So how can we explain that?
It depends on the drug. Lots of drugs are really working on the PSA itself, like hormonal treatments, targeted hormonal treatments, and others they don't. And therefore PSA is kind of mixed up in this setting. And we think that survival benefit, pain control, and of course much more imaging has to be done to see the progress or the good feeling of these new drugs.
The type of therapy a man with prostate cancer is undergoing may indicate as to whether PSA is a reliable marker of a disease progression.
I think for the approval of these new drugs, it might be, but I think I'm still convinced that the patient himself is telling us if there is progression or not.
Let's take an example of a man who's under treatment with radium-223, and his PSA is not really responding here. So do you think this man should be worried, or what do you think?
No, not at all. We have the experience that lots of patients respond very, very good and have rising PSA levels. And the survival is still in a very good manner. And therefore we calm them down. We try to not to talk about the PSA in this setting.
But let's say that PSA show a very sharp increase. How should we discuss with the patient then?
I think the main topic is pain control, imaging. We do a lot of scans now. If we see tremendous progression, if we see progression in visceral organs, then we should stop this treatment. But if it's not the case, that we continue.
So which clinical situations do you find PSA still useful?
Not really in the CRPC. We try to do CTCs, circulating tumor cells, for example, during treatment, and PSA gets a minor role. So it's a heavy discussion with doctors, with family doctors, with doctors who are not involved, and the patients, and therefore we have to educate them that PSA is not reliable at all in this situation.
So what is the risk of focusing too much on PSA? I mean, can you expect that a patient put pressure on his doctor to stop or change the treatment because of the PSA development?
Yeah, we do see that a lot. Therefore, friends of mine don't say prostate-specific antigen. They say a patient stress activator for the PSA. And there's a lot of pressure on us, and of course on the patient too. And the pitfall is that it might be that a useful treatment would be cut down and would given too short to be effective. And we have to discuss that.
So we should not rely on PSA alone, or what do you think?
Absolutely not.
Yeah.
More imaging and clinical examination in the lab. We should go for the alkaline phosphatase, maybe if possible for circulating tumor cells, and then we will see.
Yeah, and I believe that's what's in the new guidelines now, that PSA should not be interpreted alone. I mean, we should take everything into consideration, all the different parameters.
Right.
Yeah, so we agree on that. Is there still a role for patients to undergo PSA testing?
You mean generally?
Yeah.
Yeah, of course. We do have lots of data that PSA is useful. I think for my department, PSA is used at the age of 40, 45 for a basic examination. If the PSA test is lower than 1.0, we take these patients every 4 years for PSA testing. If there's any family history, or the PSA is higher than 1.0 at this age, we send them every 2 years for PSA testing. I think early detection is still a very good way. We save lives. We don't need to treat everyone at the beginning. We have the capability of active surveillance right now, and there have to be more brain involved in PSA testing.
So what is the explanation that PSA is still used heavily in patients with advanced disease and castration-resistant disease?
I think because everybody's determined. The doctors, the family doctors, the patients, the wives, everybody is riding on this horse. And it's very, very difficult to discuss that PSA does not mean that much anymore in the situation of a castration-resistant prostate cancer.
So, before we finish, I think we had a really important discussion today. What PSA means to doctors, how we can use it, what it means to patients, what it means to wives, and there's so much we still have to discuss about PSA and other biomarkers, how it should be used, and I think we have had a great discussion today about this, and I hope it will change a little bit in the future now. How we are going to use PSA, how our patients and their relatives look on PSA and other biomarkers. So there's more we can do, perhaps a little bit better than today.
Thank you very much, Dr. Bartel.
Please share this video and help spread the message, as it's aimed at helping anyone with prostate cancer better understand prostate cancer in its advanced stages and how they might better communicate with their doctors to see how well they're responding to treatment. This program has been supported by an educational grant from Bayer Consumer Care AG. The findings and conclusions are those of the faculty members.